We have Dr. Nilesh Kumar, who is a dynamic young surgeon from Bihar, Secretary of Young Ophthalmology Society, and recently they did amazing IOCMTC4 25 in New Delhi.
Thank you,
Congratulations. So he has some amazing videos. Let's see his video. There's a lot to discuss in this.
So this video is about one of those days when you think that everything is routine and you are relaxed, and then there are series of incidences that make you realize that you have to be on your toes when you are in operating theater and operating on a case. So this seems like a routine case, grade 1 to 2 cataract, very easily to chop, and the nucleus management done, epinucleus cleaning is being done right now, and it doesn't take much of time. Bimanual irrigation aspiration of the cortex is being done. It's almost getting completed, so pretty much relaxed that the case is getting over. Now just to inject the IOL and get over with it. So hydroimplantation is being processed, and suddenly I notice that the haptic is broken. The lagging haptic or the trailing haptic is inside the cartridge only.
Can you pause the video, Nilesh? So while injecting it, of course it was speed up. So while injecting, did you feel any undue pressure while injecting?
No, sir.
The IOL?
Later what I realized is whenever my assistant used to load the IOL, so what they do is they do it themselves and then give it to me. So they check it and they already have broken it. So I was not feeling that resistance because the haptic was already broken, the IOL was already free. So I couldn't feel that resistance.
So that's another thing that if you have, anytime you have undue pressure while injecting, you should realize that the haptic is not in the proper position. And another thing is what you said, assistant they load, and sometimes assistant they push it till the end.
Till the tip,
so they don't realize that they put a lot of pressure till end. So when you are injecting, you don't have anything to feel. It's just that it's going inside. So if my assistant is loading, that time I tell him just close the cartridge and give me, so that I can feel that how it's coming in the cartridge.
After this case, there are a lot of adjustment I did with my assistant loading. We got a magnifier on the OT table with light source so that they do it under magnification, and then I am just feeling it. So they load and give it to me. I do the initial parts.
So nice video so far, but why do you let the assistant come into the scenario? I mean, the eye loading and all. I think it's
a high volume surgeon,
sir. How much time does it take? His job is just to give you the lens and the cartridge. That's it.
Yes, sir. But again, sir, there is a long OT list every day, sir. And sir, just it has been trained. Those assistants are not new, sir. They have been with my father for last 15, 16 years doing it. So sometimes, and it particularly happens with no malice against them, but it always happens with Orolab IOL. It never happens with any other IOL. And now we have shifted to most of the preloaded systems. So like
you're talking about the Autoflex lens,
sir?
Autoflex.
Yeah, the AuroView, review, hydrophilic one.
Okay.
Okay, let's re-inject the visco. I have a backup lens in place. I'll just inject that inside, implant it, and then remove this IOL. Pretty routine procedure for anybody who is doing cataract for some time. So now I inject the second IOL. This has been loaded by my assistant, and suddenly that you see that haptic is also stuck, the trailing haptic inside the butterfly cartridge. Now what to do? That IOL also has opened, flipped. I tried to cut the cartridge, but that is not happening, and I have induced a subconjunctival heme attempting that. Now what I do is pull the plunger back with too much of force so that the silicone comes loose. So there is some space between cartridge and the silicone stopper, that is the blue colored one, and then with MacPherson jiggle out that trailing haptic. So that haptic is now, thank God that it was not broken, otherwise I would have two IOL to remove and then one IOL to implant. Now flipping with two Sinskey hooks, the IOL is below the first IOL and it has been flipped. So this flipping was quite safe because there was one IOL above it, so the flipped IOL was not going to abrade the corneal endothelium. Now that the first IOL leading haptic has been brought out through the main wound, and now with the IOL cutting scissors I'm trying to attempt to cut this IOL into two pieces.
Can you pause, Nilesh, here?
This process.
So I tried rope pulley method also. It also works, especially hydrophilic as they are supple lenses. So at just point you use hand over hand technique,
Yes.
it comes off.
Yes, sir.
Yeah.
But it doesn't work in my hand, sir. I don't know how. Like I always try it first, but it never worked. I tried for 3-4 cases, and then I found this a better alternative.
I also used to cut lenses like this for years, but Dr. Ravi in Narayan Netal, he showed me and I tried. It works.
Okay.
Try that.
I'll try it.
It saves times.
Yes,
Only
sir.
thing is, it also works, but that saves time, especially for hydrophilic.
Though I'm a retina surgeon, but just one tip, you can use your 23 gauge forceps also.
Okay.
The 23 gauge end gripping forceps cuts it very well, especially the hydrophilic.
Okay, sir. I'll try that, sir.
Is coming in between, and you can see on the IOL cutting forceps. This is from Joya Surgicals. No financial interest. Is very efficient, and the IOL has been cut into two halves, and one half is removed with using McPherson, and the second half is inside, but the IOL has started prolapsing because there was too much trauma on that, too much tug on that. So now what I do is use the BX forceps because it is micro forceps, so it becomes very easy to go inside with the prolapsed iris also and remove the second part. Now with the iris repositing rod, I am repositing it back, but in this I somewhat damage and create a iridotomy in that. Now the routine cortical wash is being done. After the wash, there is some amount of iris that is still coming in the wound, but when I see that I hydrated the wound, it is quite stable, and now I put air bubble, and thankfully on the first day cornea was quite clear, so that day got over very luckily good.
Very nice.
Thank you.
Did you use the same cartridge the next time also?
Yes, sir. Same lens. It was backup lens.
No, it was the same
No,
cartridge.
not same cartridge, sir.
Not
It
same.
was new cartridge.
Yeah.
I was wondering if it was the cartridge which was the problem.
Yeah, so it also happens. I have a video which I showed in one of the OPL Orolab lens. You are right. It's almost 6-7 years back. So I injected one lens, it got cut, optic. So I also used the same, scaffold technique. Just put this lens up and try to put another lens. It also got cut. So the problem was that they gave the wrong cartridge Orolab people now. So because of that, every lens which I was putting through that, it was cutting the optic. So now I had two lenses cut. Like you were
Yes, sir.
lucky that haptic didn't break. Otherwise, you also had to take out two lenses. Yeah. Arup sir, anything to add?
So when you find that there is so much of problems with a particular lens brand,
Yes,
so the best decision is to discontinue that, isn't it?
yes, sir.
Yeah.
Yes. See, earlier on, about maybe 15-20 years back, when the various companies are coming out with newer injector models and all that. See, if I have a problem with a particular this thing, so that I never had this kind of very impressive videos. Some of the things are notorious for getting cartridge issues or the haptic will come off. So just reject them and go to a better lens.
Probably from this year, I am thinking to use either a hydrophobic version of the same company. Mainly because of economical reason in our center, there are around 10% of the patient who can only afford this. But probably I am trying to shift them. We will absorb that cost, and at least we will save this trauma to the patient. So that's the plans at this end.
Another thing is you need to be careful that while exchanging lens and taking out, you need to protect corneal endothelium. So you need to use chondroitin sulfate based OVD,
Yes, sir.
dispersive OVD.
Yes,
Yeah.
sir. I missed that part, but I use a visco
Yes.
dispersive agent all the time, sir.
And sir.
So another thing is, there is no harm in extending the incision a little bit.
Yeah.
To instead of using a lot of force and iris also, there's a separation of the incision.
Yes.
So have a little extra incision, 1.2 millimeter more,
Yes.
then easily it comes out.
Agreed, sir.
Yeah, any question please? Yes, Dr. Jyoti. Take the mic please, yeah, it will be better.
While you were cutting the lens, what was the requirement of cutting it into two halves? You could just do half cut and still pull out the lens through that small incision, number one. Number two, you inserted the second IOL to use it as a scaffold, notwithstanding the fact that this is also a foldable IOL. So we really don't know how it will be able to unfold itself in a setting where there is an pre-existing IOL inside. So my take would be, as a surgeon, we first pull out the lens which is broken, then we go ahead with the second implantation. And the third thing is, the second IOL which I am implanted should certainly not be from the same company or the make which has given you trouble on that particular day. These are the 3 points I would like to see.
Agreed, ma'am. Point well taken, ma'am. I think the only thing that I would like to clarify is why I cut it into two complete halves is that iris was already prolapsing. So I didn't want to struggle too much at the wound so that more iris will start coming out. So it's better I am inside, I'll complete it so it becomes very easy and less traumatic on the
Yeah, so if iris is prolapsed, you just push it back with dispersive OVD.
Yes, sir.
Put a blob there so that
it keeps it down. Yes, sir.
Yeah, Dr. Jwant.
Dr. Nilesh, in case of stuck on that thing, then you can, instead of making a small cut, you can make a U cut.
Yeah.
Generally, I prefer U cut. Automatically, it's gone.
It
So
releases.
there's no need to pull and push again. So for learner, for younger, then I want to say, if there is a iris prolapse, better you can hydrate or suture one, and you can use the another both side port and you can insert everything. It will be very easy and safe.
Thank you, sir.
Yeah, right. Fine. Anything else? Thank you so much,
Thank you, sir.
Nilesh,
Thank you
for
so much,
showing
sir.
this amazing video. Thank you.